Good morning,
Good morning.
Natalie. Yeah, you can share your screen. Make sure it's working.
All right, how does that look?
Uh, Looks good.
Okay, you see it on your end. Perfect. I was hoping to check if the videos embedded are also working. And it seems like they are. Is that correct?
Yeah.
Beautiful. Okay. I'll just leave it up here.
I think Dr. Raul will be able to join in as well.
Great.
She she said her talk in she's done with the talk in Stuttgart, so she's available. So she might join.
Okay, that's great.
Natalie, did you include any of the laryngomalacia stuff as well or no?
I did. So this
Okay.
first,
It depends on the time. Yeah.
so you'll see I made this part 1, and I'm hoping that we can get to part 2, and that's where I included all the slides you shared.
Yeah.
I think we might be able to cover it all.
Yeah. For the people in India who have just joined, anyone can talk to about saying, what are your thoughts so far about the program? Has it been of any value? Anything we can do better? Any kind of feedback you've gotten so far? For the team in India, have you had any feedback, any thoughts on how the whole thing is going? Anything we need to do to make it better? Any thoughts? For the team in India, do you all think how this whole thing is going? What are your thoughts about it? Is there anything we can do to make things better? No, no one is talking.
Maybe we can ask again at the end when more people are logged on.
Yeah.
Dr. Mehta, should we wait a few more minutes?
No, I think give one more minute.
Okay. And you can still see that.
Yeah. We should get started. Thank you all for joining in. We have Natalie from Texas Children's, our star speech pathologist, along with Lauren. Both are like sisters. Um, we work the we all work together on a regular basis. So the idea of this talk for the speech pathologist group is mainly to understand some of the terms which come along. So you might see some of these patients will have these things happen. And the idea is to just say, one, to understand what it means by what we are saying. And the second part is how does it affect the swallowing itself? And what are the strategies you can do to help their swallow get better? So thank you for joining in. Next slide. So, uh, so that's what we are trying to see is what impact does any of these surgeries or even the pathology itself, what it does to it, how we can go about assessing it, and what are the different interventions we can do to help. So, when we talk about airway reconstruction, it's complex because there is a lot of different things which are being done during airway reconstruction. So you're doing it for a narrowed airway. So to start off, that by itself can cause changes in the swallowing, but also by the surgery as well, it'll make some changes. So we'll talk about the common etiologies and what you should think of going on with that. So let's start off. Next slide, please. So, what is subglottic stenosis? So, if you think about the vocal cords and the area just below the vocal cord is the full cricoid ring, and typically it's more common in kids because that's the narrowest part of the airway. So, when you have a tube sitting there, mostly for prolonged periods, sometimes it can happen even for short periods. So, what you see is that narrowing happening just below the vocal cords, and it can differ in severity, and based on that the patient might present with stridor but may also have swallowing issues along with it. And what you're seeing is sometimes the narrowing itself is causing the problem, but also you need to keep in mind what is happening to the vocal cords. And sometimes you can have isolated vocal cord immobility. And I want you to think about the term vocal cord immobility. And if there are any ENT surgeons in the group who are listening to it, the reason it's called immobility is we don't know the nerve function. So it's wrong to call paralysis until you have done some kind of, uh, unless you know for sure the nerve was cut or there was a EMG to do with it. So the reason, as part of that, the confirmation happens as an assessment. So when you see the vocal cords are not opening as well, or are in paramedian or almost touching position and they're not opening up, that's usually what causes the stridor. So when we say immobility, what we do is we take them to the operating room. So there are three main pathologies which can cause immobility. Number one, it could still be a vocal cord paralysis or paresis where the nerves are not working well. The second thing could be that just because the kid had an intubation, and it can be a short intubation itself, can cause fixation of the cricoarytenoid joint. So it might be the joint itself is fixed or scarred down, and that is checked by feeling for the cricoarytenoid joint. So when we are in the operating room, we check for the mobility of the cricoarytenoid joint. And if it is stiff, then you know that that might be the reason. The third reason might be that there is a scar band between the vocal cords. It's called posterior glottic stenosis. And the scar itself is not allowing the cords to move as well. So those are the three different things which could be causing vocal cord immobility. Next, please. When we are talking about airway reconstruction, we need to think about what are we doing during reconstruction. Okay, there are two main things you can do to make the airway better. One, you can make the airway bigger by putting something in like a graft, or you can take the bad part out and put the good parts together. So when you say augmentation, either you do an antigraft, you can do an antigraft with posterior split, where you split the cricoid and widen it up a little bit, or you can put an antigraft and a posterior graft. Sometimes you can just do isolated posterior graft. So these are the different variations of how it can be done. So it is important to know, especially from the swallowing point of view, that once when you see that a posterior graft was put in or a posterior split was made, that alters the swallowing a little bit more than if it was just an antigraft. And the other one is resection, where part of the anterior cricoid is removed along with the stenotic segment, and then you pull the trachea up and put it together. And we'll show you some pictures and some videos to show what it means. It is just for you to get an idea what's the alteration in the anatomy happening in these procedures. And then the second part comes is during these reconstruction, it could be done single stage, which single stage means the patient had a tracheostomy or didn't have a tracheostomy, but left the operating room without a tracheostomy. And double stage means the patient either came in with or without a tracheostomy, but left after the reconstruction with a tracheostomy. Usually in double stage procedures, there is a stent which goes above the tracheostomy to hold the reconstruction together. And that stent might be there for anywhere from 1 week to 3 months. The key thing to remember when you have a double stage reconstruction recently done, you put a stent in. One, the airway is critical. So the tracheostomy, if something happens, it can be very critical to the patient. So it is very important to keep that in mind. The second thing is, because you're putting a stent in, it changes the dynamics of your swallow because you're holding on to it. Um, The same thing can be done with cricotracheal resection as well. It can be single stage or double stage. We'll talk about tracheal slide, which is a little bit different yeah, in the few slides later. Next slide, please. So what we are seeing here is what I mean by anterior graft. So you take a little piece of cartilage and then you build the front wall of the trachea and you put a little piece of cartilage in the front. When you're doing a posterior graft, you can see that the back wall of the cricoid is cut, split open, and then you put a little piece of cartilage in there. And again, um, when you're doing a posterior graft, usually it is done if there is an identified posterior glottic stenosis or some form of vocal cord immobility, and also in severe subglottic stenosis. So you want to augment as much as possible, and that's when you put the posterior graft in. Next, please. So this is one of the animation videos of from Cincinnati Children's showing what it is so that you understand what it means by. So we take a little piece of rib and then we carve it out. Yeah. And then we place it in the front and it's sutured in. This has comparatively less effect on swallowing, but it does affect the swallowing, especially if when it is a double stage and there is a stent sitting up. Then what do you mean by slide tracheoplasty? Again, when you hear the term, it's basically in certain conditions, we cut the trachea right in the middle and then slide open up the back wall on one side and the front wall on the other and slide them so you have a shorter trachea but a wider trachea. So again, when kids have breathing issues, um, this is commonly done in complete tracheal rings, kids with complete rings who have a narrow airway. It can be done for other tracheal anomalies as well. Next slide, please. This is a cricotracheal resection where the front half of the cricoid is removed. And you take out the stenotic part and you're bringing in the good parts together. So it does alter some of your swallowing mechanism as well. And then we were talking about the stents. So you have a piece of plastic which is sitting right above. It basically blocks the airway right above. And depending on why you're doing it, people leave it for a certain period of time. Next, please. The other thing to keep in mind is the stent closed or open. Most people nowadays will have in some way closed, whether you suture it or you have something to block it. As you can see, if you have an open stent, it will lead to aspiration. It'll lead, as the kid is swallowing, one, the mechanism itself is altered, plus you're making a big hole opening there. So the chance of aspiration is higher. And there was a paper from Philadelphia which showed that because some people were still doing open stent, but once that paper came out, more and more people who were doing the closed stent because it makes sense. Next, please. So this is just a video of antigraft. It's again, um, basically we are sizing the airway, trying to make it bigger. You don't have to see this. Let's move on. Next slide, please. Yeah, this is the stent being placed. Okay, Natalie, your stuff. So you have a patient who's had. So before we start, it is also very important that these patients, even before they go for their surgery, to understand their swallowing status. Because if the kid is already aspirating, then it changes your thinking of what should be done. Should you wait for assess why this aspiration is happening? Can you fix that before you do it? But also have an idea of their feeding status to say how much what they are taking by mouth safely. A lot of times you might have to do that assessment, and then the post-op care comes in. So Natalie.
Yeah, so I'll take it from here. So yes, like Dr. Meadow was saying, pre-operatively, it's just gathering the baseline feeding information, and this will help in decision-making post-operatively. And what I mean by that is we're completing a clinical evaluation pre-operatively, we're understanding and getting information from parents and caregivers about what the patients are eating and drinking normally, what kind of vessels they're using, what a typical meal looks like, breakfast, lunch, and dinner throughout the day. So we're getting a really good picture of that. If we're concerned about safety and efficiency with their swallow, we may recommend a fiber optic endoscopic evaluation of the swallow, the fees, or a video fluoroscopic swallow study. It really depends on what we find, what the parents are sharing about symptoms that they may be seeing at home. So the importance of the information, we gather preoperatively is that it identifies dysphagia and airway invasion preoperatively to prepare the medical team and set realistic expectations. And then it helps identify any feeding preferences. It helps prepare the family and patients, as well as the inpatient SLP team for their post-operative stay. So it gives us a good snapshot as to what the patient was doing at baseline. So post-operatively, our goal as speech pathologists is to assist patients in resuming their oral feeding and return to their pre-operative diet safely. We want to provide guidance and strategies to facilitate oral consumption. Again, expectations though need to be realistic. From the get-go, we're saying this process of getting to baseline diet may take some time. These patients may not be getting to that diet quickly, and having these tough conversations with the patients and their caregivers is really important. So again, post-operatively, we're completing a clinical evaluation at bedside. If needed, we're completing an instrumental evaluation, and then some general points that we think about or consider are returning to a preoperative diet is, again, a process, and this may continue even post-discharge. So these are patients that we may see in our outpatient kind of setting to help guide and get them back to where they were. Transient dysphagia may be present, but expected to resolve. And again, baseline information will help you understand, this is outside of normal for this patient. However, we think that this may resolve with time. In younger patients, we may see that skill regression may occur temporarily. This may look like a toddler taking textured or soft solids, not doing well with these textures, and maybe going back to a smoother puree or something that's easier for them and won't cause discomfort. And then considering comorbidities comorbidities such as genetic or neurological conditions that may pose additional challenges. Okay, so general considerations for post-op stay. During our clinical swallow evaluation, we think about the medication or narcotic wean. So when we go to bedside, it's really important to consider what is the patient's state? You know, their level of arousal. Are they alert? Are they able to, you know, follow directions and tell you what they're feeling? Just think about their general medical stability and withdrawal of the medications. Respiratory wean, this is huge. If your patient can't breathe, they're not going to do well with the swallow. So consider, are they off CPAP? Are they gradually weaning off respiratory support? And it's really, really important to talk to nurses and just the team about how they see the patient, how they're tolerating this wean, and where they are in the process. So getting clearance from ENTs and asking very directly, do we feel that this is an appropriate time to go ahead and start feeding orally? Think about global deconditioning. If they've just gone through a procedure, we have to consider, are they in the right, for example, position physically? Do they have the strength to hold up their head and neck and have, you know, be in the most optimal position for feeding? Consider how deconditioned they may be postoperatively. Secretion management is huge. Again, if our patients are having a hard time managing secretions postoperatively and they weren't beforehand at baseline, this is huge and something to really consider, and maybe take things a lot slower and really focusing on secretion management, getting them to be safe there at that level before you even progress any further. Introduction of liquid and food trials, very gradual and influenced by their baseline diet. Small, careful sips or bites may be kind of based on how they do. So if we see that our patients are tolerating these small bites just fine, they look comfortable, it seems like they're doing things in the way they did before, this gives us more confidence in kind of progressing a little more. But again, very gradually, mindfully and thoughtfully, because the last thing we want is to, you know, set them back any further. So again, gradual increase in volume, no rush with that. Okay, double stage considerations. Dr. Meadow was referring to this earlier. Immediately post-operatively, we want to think about the fact that the stent is sutured to strap muscles, resulting in reduced high laryngeal elevation. So the swallow may be a little uncomfortable. I have heard some of our older patients complain of discomfort during the swallow. Post removal of the stent, again, we're assessing clinically, they may have altered sensation due to that stent placement and removal, and then continued modifications may be needed. And we'll talk about what those modifications may look like. Follow-up in clinic or an outpatient setting is important, and this will help us determine what any lingering deficits are still there, what concerns are now, you know, at the forefront, or what parents are thinking about, what looks different. It's very dynamic, our assessment, and so we have to make sure that we're evolving as the patient is evolving and changing and, you know, progressing. So we may consider, again, instrumentals if concerns persist, but this is not something that we're rushing to. It's thought about very carefully. We're considering, you know, how many swallow studies they've had in the past and what information or what will change with the results of a new swallow study. How is it going to help inform, you know, future kind of progression or how this patient continues to do? So in terms of dysphagia intervention approaches, there are two kind of ways that we want you to think about it. There are direct interventions and then compensatory strategies and techniques. Direct interventions are techniques intended to change the physiology of the swallow. These are maneuvers and specific exercises. If you guys were able to join us at the last talk, we kind of went over some of these and I'll review them in just a second. And the compensatory strategies are more indirect. We have hopes that they'll eliminate symptoms of dysphagia and improve the safety and efficiency of the swallow. So direct interventions. These are the ones we were talking about in our last talk. We refer to a bolus hold, for example. This is where we ask patients to hold the liquid in their mouth prior to the transfer of the swallow or initiation of the swallow to allow time for the volitional closure of the airway. A double swallow is a use of a secondary swallow, and this is sometimes a strategy we use or an intervention we use to help our patients when we know that they have residue that they're having a hard time clearing. So this is really working on that pharyngeal squeeze. The supraglottic swallow sequence is the closure of the supraglottic or glottic area before and during the swallow, then a cough to clear. Okay, these are all like safety measures, if you can imagine, that we're taking to help ensure that we're reducing the risk of anything getting into the airway. Effortful swallow is swallowing saliva or small sips of liquids or solids with extra effort. And this can get kind of tricky with our smaller patients describing all of this. By smaller, I mean younger patients. With our kiddos who cognitively can understand and follow directions, we may say something like squeeze those muscles, your swallow muscles with extra effort. And the goal of this is to really strengthen the muscles involved in the swallow to facilitate the bolus flow through the pharynx. And then ultimately, we want to make sure that that residue is being cleared. Head rotation is turning the head to the weaker side to help direct the food down to the stronger side of the throat. And this can close off the damaged side from the bolus pathway. Again, all with the goal of avoiding airway invasion. Chin tuck, we talk about flexion and how it decreases the space between the base of the tongue and the posterior pharyngeal wall with goals of protecting the airway. Lastly, I put an asterisk here, oral motor exercises. These exist, you'll read about them, you'll see a lot of information about them online. It's very important to think about how we use oral motor exercises though, and making sure that we're keeping all these exercises very specific and in the context of feeding. So in isolation, they're not going to do much. Random tongue exercises, putting tools in your mouth, vibratory, utensils. What's important is to practice the skill of actually eating. So working on lateralizing food, moving the bolus to, the molar tables and teaching patients how to do or practice movements that will make them better at doing a specific skill, right? So we have, one second. Okay, so the indirect therapeutic techniques that we're talking about relate to positioning alteration. So alignment of the head, neck, trunk, extremities to facilitate the coordination of oral motor movement. So thinking about how important it is while considering the patient's age, their gross, motor skills before, right? And what's developmentally appropriate for them. With the caveat being a lot of our kids have other comorbidities that may be impacting what they're capable of doing. So providing all the support to obtain this most optimal position for them. And then sensory motor interventions is the use of structured sensory input to modify oral actions. What we mean by that is modifying the bolus, for example. So the volume, maybe we present, single sips through a spoon to start, then single sips through an open cup, thinking about what they were doing before. We're not going to present a straw randomly if they weren't doing it before, but we may do single sips from an open cup or single sips from whatever it is that they were doing before we continue and progress to consecutive sips. Texture, this texture grading is really important. And so thinking about, a smooth puree and what the next step might look like is incorporating some kind of, lumpiness or texture to that puree, and then gradually working up to, soft and dissolvable and more solid, hard solid foods. Taste and what that might look like, introducing a variety of tastes when the patient is ready, from sweet and salty and savory and things like that, tastes that are stronger or more mild. And temperature is really important in that when a patient feels a difference, whether it be cold or warm, it may help kind of initiate or get that swallow going. Alteration of fluid viscosity is huge. So slowing the flow of liquid is important, and it helps with the goal of facilitating oral control and allowing increased time for patients to achieve airway closure. I'll talk about this a little more in the second part of our talk, but this is taken really seriously and always, a conversation we're having with the whole team. Okay, so GI and our registered dietitians or ENTs together, we're talking about how old is the kid, what thickening agents are appropriate for them. We're never thickening without the completion of an instrumental swallow study. So very mindfully thinking about it, but always considering the fact that a slower flowing liquid may help with the swallow coordination and that timing of airway closure. Okay, so these are wonderful published studies that I want you to either take a picture of this slide. There's also a reference slide at the very end you can take a picture of. We've put this list together for you, and it's all related to swallowing and airway reconstruction. You can refer to it later, but we won't have time to go through the specifics of each one. I've put together, though, some take-home points. So very quickly, I'll read through them. Transient dysphagia is common, as we've talked about, after laryngeotracheal reconstruction. Preoperative feeding skills don't correlate necessarily with postoperative airway protection abilities of a patient. The completion of a feeding assessment before airway reconstruction provides a means of identifying patients with poor airway protection mechanisms, and that may compromise the patient after reconstruction. So all the information you get before is super important in understanding what to expect after, okay? Postoperatively, feeding difficulties occur in patients with pre-existing feeding issues, such as oral aversion and/or texture resistance, regardless of reconstructive surgical procedure type. Last 2 points, compensatory swallowing strategies were effective in decreasing aspiration associated with swallowing in oral feeders postoperatively, okay? And it helps them get back to their baseline diet. Lastly, safe oral feeding early in the post-op period is possible with a rigorous multidisciplinary approach. And that's probably the biggest takeaway from all of these talks is it's huge to work with the entire team to get these kids back to their baseline diet or even just progressing after these operations. Okay, here's that reference page I was referring to. And then Dr. Mehta, if you'd like to take it from here for part 2. There you are, Dr. Mehta.
Talking about, I'll just add what we said and just summarize that.
Yes.
The key thing would be to have a good assessment before, but keep in mind that depending on where you're looking at swallow, the swallow keeps hinging. And majority of times you can end up getting a safe swallow, but you need to keep in mind where. So for example, have a stent in place, the swallowing will be different. When the stent comes out, immediately after the stent comes out, it'll be different because the sensation is not normal yet. It takes a little bit of time for the sensations to come back. Plus, they have learned a certain way of swallowing with the stent in place, and now the stent is out.
Right.
Yeah, Deepak.
Yes, we can hear you.
Deepak.
Kick me for a second. Okay, let's talk about
Part 2.
I'm not
hello.
slides.
I think someone may have a question, Dr. Mehta.
Yeah. Go ahead.
Okay, maybe not.
Can you hear me?
Yeah, I can hear you just fine.
But I can't see your slides. It says I can't see. I don't know if everyone else can see.
Oh, can everyone else see the slide?
It's seen.
Okay.
It's seen. Laryngeal malacia and swallowing part
Okay,
2.
now I can see. Now I can see. Now
Yeah.
I can see.
Yeah.
Okay.
Yeah. Go
Anyone
ahead.
had any questions or you had any experience with airway reconstruction, post-op management? Anyone feels like adding anything to what we said? Feel free.
Deepak.
Mm-hmm.
Thiru here.
Yeah.
Yeah, right now I'm in 8th inch, just behind Acropolis. So there'll be a lot of noise around. So still, so I would, like to ask a few questions. One is this post double stage procedure. when the
Uh-huh.
stent is in. If
Uh-huh.
you're not removing the stent within a week or so, so you will be starting oral, how
Mm-hmm.
many days after the surgery you will start oral when the stent is in. And
Well,
when the stent is out, how many
mm-hmm.
days later you will start swallow. That is first question. Second question
Mm-hmm.
is, in case if you have already started swallowing when the child
Mm-hmm.
is having a stent inside, and does that make any difference when you bring the stent out? Anyway, the child is already
Mm-hmm.
swallowing, right?
Mm-hmm.
So when you remove the stent, it's going to be the same, right? So in even that time, there will be some alteration after removal of the stent.
Yeah. So good question. From my point of view, whenever you think the child is awake enough, so it depends of after the stent placement, for some reason you have decided that the trach shouldn't move because it's almost like a fresh trach, and they are sedated, then you need to hold off. If they are not sedated and they are awake enough, then you can start the swallowing right away. The key thing to keep in mind is one, it is a little bit painful to swallow. Uh, so you'll have to modify their swallow or what they're swallowing based on that. And Natalie, you can add what you think about it as well. But uh, that is the main thing you're worried about. If the stent has a closed upper end, then I'm less worried about aspiration. It's mainly making sure they're getting back to what is easy for them to swallow, and just keep that in mind. That is when the stent is in place. When the stent comes out, it is a different picture. One, you don't have something which is holding on to the larynx and making your swallowing. And saying that, even when initially it'll be different for them when the stent is in, as few days go by, that their swallow gets used to it and they'll get better. So that will change in a few days time, but it is important to recognize and just warn the family like, hey, this will happen, this is normal. Just slowly keep introducing food which is okay with them to swallow. So obviously things like purees will be a lot more easier to swallow compared to solids. When the stent comes out, it's a different picture. One, the the safe, you have to worry a little bit about potential for aspiration, because the stent, you have widened the airway. There is a chance that the kid who was not aspirating might start aspirating. Most times it's temporary, and you can make it better, but it is important to keep in mind. The other thing what has happened is, because the stent was sitting in there for whatever period it was there, it alters the sensation. So the same protective mechanisms are not there. So it takes some time for that to get better. Um, so it is more important to keep those things in mind. I would prefer for them to start eating as soon as possible. Um, and I don't have like a timeline that I wouldn't make them eat. If there are medical reasons for them not to eat, for example, they are too sedated or paralyzed or things like that, then it's a different thing. But they are awake enough to swallow, I would prefer for them to swallow sooner. Again, some of that goes with the assessment. If the kid is obviously aspirating and you see some food coming in through the trach, then it is a complete different picture. Then you say, hold off a few days, let things settle down. We reassess in few days' time. Natalie, would you add anything else?
So no, that's the major one, is making sure that first of all they're awake and alert enough to participate and really work on very intentionally accepting the trials you're trying, and then taking it slow from the beginning, and only progressing and getting closer to their baseline diet as you see they're doing well and presenting with similar kind of skills as they were beforehand. And then, with the stent removal, the reduced sensation, so being mindful of what that might look like in terms of, they're not going to be presenting necessarily with the symptoms like coughing, choking, anything, or congestion. So thinking about maybe incorporating changes or modifying bolus size or things like that. So you're taking smaller sips or starting with even some ice chips or whatever it may be to really carefully progress with that.
Any other questions, thoughts? Any of the speech pathologists have any experience or anything else they would do, they have done in their practice? We need to keep this interactive, otherwise it'll be one-sided talk. Don't feel shy to ask questions.
Or if you do things differently, we're happy to hear what you do and talk about, how that's working for your patients.
No one? No one wants to say
Hello.
anything. Let's
Yes.
move on. Yeah, Thiru.
Yeah, I mean, it's the same, practice. Whatever you are doing, we are also doing. Except that the post stent removal. So far, we have not had that much of a problem after removing the stent because already the child has developed swallowing to some extent, and they're they just pick up without much problem. But the valid point of whatever you and Dr. Deepak has said just now. So we need to keep a track of on the sensation. Maybe the child can aspirate a little bit. There may be a silent aspiration or something, and that will be a major catastrophe in case if you are not giving importance to that. So that we'll keep in mind hereafter. Thank you. So you continue, Gautam.
Yeah. So next part we'll talk about laryngomalacia and how it affects the swallowing. Next slide. So what we'll do is we'll talk about what is laryngomalacia, how much of swallowing the kids with laryngomalacia have, and what role the speech pathologist has in it, and how do you assess in these patients. And then one of the procedures done for kids with laryngomalacia is supraglottoplasty. We'll show you what supraglottoplasty means and how does that impact the swallowing itself. Next slide. So, laryngomalacia, can you play the video? Laryngomalacia is basically, you see in this patient, there is a short A fold, little bit more curled epiglottis, and sometimes the arytenoids and the cuneiform cartilage is collapsing in as well. So what happens is, this is the commonest cause for stridor in neonates. And what happens in these ones is when they are breathing in, they have the airway collapses. So that's why you get inspiratory stridor. So they'll be having, because when they are breathing out, everything opens up. So it's fine. So as you see in this one, it is collapsing in as they're breathing in, and it opens up as they're breathing out. So that's why you see the inspiratory stridor. And there is, when you read literature, there's a huge range of people saying how many of these patients have reflux, and we'll talk a little bit about it because there's a lot of different things the speech pathologist can do to help. And the key thing is, majority of these patients, more than 80% of them, will get better with conservative treatment, in the sense they don't need a surgery. You can manage it. And a lot of our management happens with the speech pathologist. So we make the diagnosis, and then we get an assessment, and then they are managed by the speech pathologist. And we'll talk more about that. Next, please. Yeah. So there was a seminal paper from Dana Thompson from Chicago where they showed that 71% of all laryngomalacia patients have some form of dysphagia. And most studies have shown about that range, about 65 to 75% range. And when we say dysphagia, it doesn't mean all of them were aspirating. It means that they have some form of problem with their swallow. And it makes sense because when you are, especially in an infant, you have suck, swallow, breathe pattern where you are sucking, then swallowing, and then breathing. When that breathing part is affected, it does affect your swallowing. So keep that in mind with any patient with airway problem, especially in infants. It does affect their swallow because you're changing how they're doing things. And the other thing to keep in mind is most of these kids are mostly on liquid diet, right? They're having milk or formula or those kind of things, and which is more difficult to coordinate. So that's why you might see quite a few of these patients have some form of aspiration or penetration. And next, please. Sorry. Um, so there was a paper I was involved in. We looked at all. So this was when I was in Pittsburgh. We looked at all our patients with laryngomalacia who had come to the clinic, and then um, we saw this is a realistic because sometimes when you look at papers, some of them might be ones which were more severe had come their way. In some centers, all laryngomalacia comes their way so that they get a better understanding. So I would say this is more representative of all kinds of laryngomalacia. So we had some mild, quite a few moderate, and some more severe form of laryngomalacia. And sometimes you think that the abnormal swallow happens only in the severe ones, but what we found is um, uh, uh, it didn't matter. Even if you had a mild form, it can affect your swallowing. And the only thing we saw is the more severe it is, it will lead to failure to thrive. So for me, the failure to thrive becomes a very important um, aspect of the assessment of laryngomalacia, where if the kid is not swallowing well, so the kid is having issues, failure to thrive is mainly because one, he or she is using a lot of energy towards the breathing. On top of it, they're not swallowing as well. So when it comes to life, I would rather breathe than eat. So eating becomes the next thing, not that important compared to breathing. So failure to thrive is a important tool when you're assessing. If you see failure to thrive, then you need to address it. Sometimes you need fortification to make them gain weight more, or otherwise, especially in the severe cases, they might end up needing supraglotoplasty. So in our center, all patients with laryngomalacia will have some form of swallow assessment. And it starts off with clinical assessment, and then you can decide. And not all patients need a full swallow assessment. They just need a clinical assessment to start. And then majority of the patients, because you're trying to assess why they are having the stridor, so you end up doing a flexible scope anyway. So we invariably do fees at the same time. So the importance of fees is, or that having the speech pathologist in the room, is because a lot of these patients have swallow issues and also may or may not have some reflux kind of symptoms. So it is important to address all those things as you go along. In a small number of patients, we will get a swallow study as well, especially if the fees was inadequate or there are more questions to answer, or there are patients who are more complex. They are syndromic kids, they have other neurological reasons for their swallow to be affected. All those things just um, makes that you need a more thorough investigation of the swallow, then we do a swallow study. Next, please.
All right, so I'll take it from here, Dr. Mehta.
Yep.
So the role of speech pathologist in this patient population is important in that, again, we're working very closely with ENT. These kiddos come in with a really hard time breathing. And so infants with airway compromise or respiratory distress may not be able to safely coordinate this suck, swallow, breathe, as Dr. Mehta was referring to. which is what they need to do with bottle drinking and nursing. And so this difficulty or this breakdown in that coordination then leads to a dysphagia and sometimes even aspiration. So as speech pathologists, we're really thinking about what we can do and what we can alter even within the context of a clinical evaluation. So that a huge one is pacing. And so I'm referring to a couple of things when it comes to pacing. A lot of times it's how we're offering, for example, the bottle, or so instead of making sure and really reinforcing the importance of letting the child kind of lead, or making sure that we're not drowning essentially the patients when we're offering the bottle. So we are maybe positioning the bottle in a different way. Instead of filling that nipple full of milk, maybe it's half full, and we're teaching them to really bring down that milk so that as the patient is actively sucking, we're providing and we're giving the milk. But as they're not, and they're taking a second to breathe, which is the case for a lot of these patients, we're tilting that nipple and letting them have a second to catch up. And then meeting them where they are, they start sucking, we're offering them the milk. A lot of times, some of our kiddos come in and they're not pacing, right? They don't have the ability. Sometimes even with neurological conditions, right? Their ability to know when to stop isn't there, or, they have deficits in that area. So we're telling parents, after maybe 5 or 6 sucks, we're going to tilt the bottle down so that we're almost forcing the patient to stop and breathe. So really optimizing the breathing so that they can be more efficient and safer as they bottle feed. So really optimizing suck, swallow, breathe pattern as much as possible. Positioning, we're also talking about the baby and putting them potentially in a sideline position. We find that oftentimes when our parents come in, they're saying, we notice the noisy breathing gets worse when feeding. And we ask, well, what position do you feed your child in? And a lot of times they're on their back. Parents are tired, or maybe that's just how they learn to feed their baby, and they're completely flat on their back. And so we ask them to turn the baby onto their side to help the breathing. And so because of the floppiness, we find that when babies are turned to their sides, somehow they're able to breathe a little better. In conjunction, right, with the pacing, it really helps with that coordination. So we're turning our babies to their sides. Depending on whether they're presenting with reflux symptoms or not, we may ask our parents or caregivers to hold them onto their side and then bring them up just slightly so that we're not really making the reflux symptoms worse. Another thing to consider with positioning, I know this is getting kind of detailed, is to think about, if there is a vocal fold paralysis or paresis. So really important information on that can be gathered during the fees, where the ENT will share, hey, maybe it's a patient with a cardiac history, their left vocal fold is still not moving. So making sure that then we're turning the baby to the right side, right? So gravity helps that left side come down. And all these things are what we think about as speech pathologists. Nipple flow rate modifications. We're very fortunate in that we have a plethora of nipple flow rates and bottle systems, but really it's a matter of slowing the nipple for the flow rate down a lot of times. So another thing to consider is parents will say, my child is just breathing really hard. I just took, a needle and poked a hole to make it larger. But oftentimes what happens then is they're getting so much that they're being flooded. These infants are being flooded with liquid, express breast milk, formula, whatever it may be. So we have to kind of help the parents understand and find that balance, that whatever kind of combination works for their child. And that's information we can really find and get from completion of instrumental swallow evaluation, like a FEES or a video fluoroscopic swallow study. And especially with the video fluoroscopic swallow study, you have more time to kind of go through combinations of different liquid viscosities and their appropriate, nipple flow rate that they may bring from home or that we may have. You'll see there we listed liquid viscosity. Again, super important to talk to the team, consider the patient, their age, and their medical history to see if we, thickening agents are something that we can even use. So this is all, of course, we have to consider the fact that we have to complete a swallow study to know if it's even beneficial. This is not something we're blindly doing. So the goal is to slow the flow of the liquid, which then facilitates oral control and allows increased time for airway closure. Okay. And so again, this whole time we're assessing, we're providing education, we're training parents, and it's oftentimes, it's a hard conversation because our patients and their families come in and all they want is to feed their babies. And so here they're coming and everyone's, watching them. And so it's about kind of supporting the parents and saying, we're on your team. We want to help you modify what you're doing to feed your baby in the most effective way possible so they can grow. I find that sometimes when you start changing things up really quickly during an evaluation, it's parents become overwhelmed and flooded with feelings, I think, of guilt, of, what did I do wrong? And it's more like, no, you're doing everything right. You're trying to feed your baby, but we just want to make it safer. We want to make it more efficient so they're not working as hard. All right, Dr. Menahee.
Yeah, so Natalie, I want you to talk a little bit
Yes.
about how do you set up for fees for
Sure.
these patients. Let me say a few things before you start. So when you are doing an assessment for someone with a stridor in an infant, an important aspect of that assessment is doing a flexible scope.
Yes.
And when you're using a flexible scope, it is important to keep in mind that when your speech pathologist is done pre-assessment, clinical assessment, it gives you a very good idea of where they are from their swallowing point of view. Are they coughing and choking with their feeds? Are they taking a long time? Are they getting tired as they're going along and then they start to have problems? So that gives you a good idea of where your modification should be and prepares you to say, what do I want to achieve with my fees? So that's where the thing comes in, because once you put the scope in, you have a limited time, but you want that information to be as helpful as possible. But at the same time, there are a lot of things you can learn by doing that fees. So from the ENT point of view, we are trying to assess how bad is the laryngomalacia. Is there any other pathology which is happening? So it gives us a lot of that information. But there are a lot of feeding information which can be gotten from a fees. So,
Yes.
Natalie, can you add how do you set up for a fees and how do you go
Sure,
about doing the
sure.
fees?
And before going into the setup, I think the key, what we always think about is how safe are they and how efficient are they? That's the most important thing. So if a family comes in and they're saying that when the child is feeding, using the bottle they have, their home bottle, they are sounding wet, they are sounding, they're coughing, they're choking, and they're reporting all these overt signs of airway invasion, then we think about, okay, maybe we need to, like, right off the bat, think about having options available that are maybe slower flow nipples. If patients are saying that we're already thickening, they don't really have like a specific kind of recipe they're using to thicken, but they've been told that maybe thickening will help slow things down. Or from a GI and reflux perspective, they've been told this thickening may help reflux. So we think about all of that and how we set up, because we may have a thickened liquid available to test along with the thin liquid, along with their home nipple, so whatever they're currently using, and something slower. So if, like I said, we're fortunate with the Dr. Brown system at our hospital where we have, a gamut of flow rates available. So we may have the next level up or the one below, just based off of the symptoms that parents are reporting. And again, we're also thinking about how are you feeding position wise. We ask, how do you feed your child, right? So a lot of times we may start in that position and see, they're in cradle position and they're sounding pretty awful. We may then turn during the study. It's not easy, because oftentimes the discomfort really gets to these small children, the infants. We turn them onto their side. So all things to consider and all things we have to very meaningfully plan beforehand so that we get the best study. And then thinking about another thing that just came to mind is a lot of times our infants are coming in with a swallow study done, for example, during their inpatient stay. So if if parents are saying they're doing better with this flow rate, and that's something that maybe they have aspirated previously in a swallow study that was done before, trying that one out so that we can see if they're safe or not. But always, always with the caveat of, it is a wonderful study. We get good information, but the information we gather from a fees alone is not going to make us feel 100% satisfied or believe that they're 100% safe all the time, because it captures a moment of time. Like Dr. Mehta said, it's a brief period. And again, we're missing out on the moment of the swallow because of that whiteout and that light that's reflected. Anything else you want me to add, Dr. Mehta?
It keeps kicking me out.
Sorry.
I can't see the slide again. Something is happening. Anyway, so I can't see the slides, but I'll just keep going.
Hold
There are two
on.
ways of assessing.
Hold on. Can you see them now?
Yeah, I can see them now.
Okay.
So there are two main ways of assessing the airway. The most important one is the flexible scope, because it gives you a dynamic assessment of exactly what is happening. In a small number of kids, they might need to go to the OR, and you can do a rigid bronchoscopy on those kids. Next, please. Yeah, with the flexible laser laryngoscopy, you can see the whole airway from the nose right up to the vocal cords. You can see and you can understand a lot of things going on with them. Next, please. We talked about this. Um, the key thing with doing the fees is it helps you gather a lot of other information as well. Are they having nasopharyngeal regurgitation? If you're seeing secretions already sitting there, normally you shouldn't see secretions sitting while you're doing a fees. If you see secretions already there, that means they're not able to even clear their secretion properly. Start thinking about that can be a problem that might be leading to some aspiration. If you might see some residue, but it's not clearing, like we talked earlier, sometimes they need multiple swallows to clear. So that gives you some idea of what needs to be done. And also, rarely you will see some black backflow from the upper esophageal thing. That means the kid has significant reflux, which is causing it. And also, keep in mind, kids with laryngomalacia, especially with more severe reflux, they might have an altered sensation of their larynx. So that's the reason they might be aspirating as well. So sometimes you might have to treat that to get there. And the other thing is, when you're doing a fees, it is more a nuance of understanding what is happening, because the key moment when the swallow happens, you get a whiteout. So a lot of your information is around what you're seeing there to get an idea what is happening. So if you might see a little bit of premature spillage, um, which is okay in infants. But if you're seeing it, it's going towards the aryepiglottic fold and it's trying to get in, then you know that, okay, this kid is at risk for aspiration. So what can I do to change it? So it is a nuance you need to, as more and more you watch it, you will learn like what how to interpret with them. Next, please. So in our paper, what we saw was in mild patients, the swallowing dysfunction is about 40%. Um, oh no, of all the patients we had, about 40% of them had mild disease, 40% were moderate, and 20% were severe. And a lot of them had some form of swallowing dysfunction, yeah. And people talk about secondary airway lesions, like, oh, patient do have tracheomalacia as well, or have a mild form of subglottic stenosis. Um, and there is, again, we talked about GERD. Keep in mind when you add laryngomalacia along with comorbidities, like neurological disease, craniofacial anomalies, genetic syndromes. It just makes it even more complex. And also, the other group is kids with cardiac problems. Next, please. So in the same series, what they found is aspiration was more common in severe. It makes sense, right? As the severity of the laryngomalacia goes up, the chances of them not coordinating well and not protecting the larynx is higher. Next, please. And the other thing we learned from that is also it is not a static disease. It can get from better to worse over a period of time. So it is important to have that connection and let the parents, especially when you are deciding to just watch them and let them grow, it is important to keep in mind that things can change. And as they change, you modify your treatment. Yep, same thing. It progresses from moderate to severe over a period of time in some of these patients. Next, please. Uh, when they looked at the severe laryngomalacia patients, almost all of them had feeding difficulty. And the other thing is, a lot of these patients had either cyanotic spells or apneic spells as they went along. So that becomes an important part of assessment. Next, please. So when do you do surgery for laryngomalacia? If there is worsening stridor, things are just getting worse, and you see in this patient, the arytenoids are flopping in, the A fold is pretty small. And the key thing for me, as I told earlier, is failure to thrive. If they're not gaining weight, so look at the growth chart to say what's happening with it. If they are not going along the growth chart and they're starting to come down, start thinking like, what can I do to make this better? And supraglottoplasty is a surgery which is custom made to what is happening. So that's why for the ENT folks here, it's basically looking at what structures are collapsing. So, for example, in this case, the arytenoids are flopping in, the E folds are shortened. So, you need to customize your supraglottoplasty based on that. Next, please. So, what do we do in supraglottoplasty? Yeah, next, please. Went through all that. Okay, reflux management. Um, Again, here, uh, a speech pathologist can be helpful because sometimes when you talk about reflux, and I told you there are papers which say 100% of these patients have reflux, and some papers say 20%. So there's a big range. And the reason is because none of them we are doing an objective assessment. It is based on either symptoms or some findings. Um, and a lot of these patients, why do they have an increased amount of reflux? You need to think about multiple reasons. One, your swallowing is affected. Two, you're creating a negative pressure above. Three, infants don't have a strong um, lower esophageal sphincter. It is still evolving. It is not strengthened. It can take up to a year before it becomes strong enough. So you're creating multiple reasons for them to have some of the food come up. And it's a different thing from and at baseline, all kids have some spit up. So it's differentiating from what would be a normal spit up for most of these infants to what is really a problem and when you should be treating it. So, a good way to think about it is it's not normal for infants to vomit on a regular basis. So, especially right after feed, if they're vomiting quite a bit of their feed up on a regular basis, that's not normal. So, those are things to keep in mind as part of your assessment. Natalie, can you say what changes you make in these kids who we worry that may be having reflux episodes?
So I think pacing is what comes to mind mostly, is slowing our kiddos down, taking breaks throughout the bottle feed or nursing sessions, giving them ample time to burp, and then holding them again in terms of positioning more, a little bit more elevated or upright. This might look or be a little more challenging for nursing mothers. So thinking about working on different positions with them, and lactation consultants may be very helpful in the positioning aspect and optimizing latch for that. And then holding our babies more upright, our infants more upright after feeds for 20 to 25 minutes, which does seem like a lot, but really helping and really getting that liquid down. Thickeners, we don't, as speech pathologists, thicken for the purpose of reflux. However, if GI recommends it, and it's something, with our more severe cases, that at the GI level, obviously with the guidance of our registered dietitians, they're recommending it, then we will help make sure that it is at the liquid is at the liquid viscosity that was recommended, but also that they're using the appropriate flow rate. So if they're they're thickening, not very much, but they're thickening, and they're using, for example, a level 3 or a 4 nip or something that's very fast, again, we may be flooding our babies, and then they're getting too much, and then their reflux gets worse, and the breathing is worse. So it impacts then that the coordination of the swallow altogether. So all these little things and the nuances of it are very important.
Yeah. And in the Indian setting, I don't know what you guys use as thickeners. Probably rice flour, oatmeal. Those might be options. Um, but again, if anyone has any thoughts on how they go about thickening, you can add or you can chat about it. Uh, a small number of patients need some form of medical treatment. So you can start off with H2 blockers like ranitidine, famotidine. Um, some patients might need a little bit something stronger, like omeprazole, esomeprazole, pantoprazole, whatever is available for you guys locally that can be used. The key thing for when you are using a proton pump inhibitor is to warn the parents that they need to not feed the baby for at least 20 to 30 minutes um, until 20 to 30 minutes after the medication. Otherwise, it is less effective. That's not a problem with H2 blockers, but PPIs, you need to just the mechanism of how it works. It has to go and block the proton pump, right, for it to be effective. So if you have already given food, then those pumps will not be blocked. Then it won't be as effective. Fundoplication is very rarely done in these patients, but it is something to keep in mind. In the very, very severe ones, you might have to do it. Next, please. So when do we do a rigid scope on this patient? So patient where you have tried the conservative methods and it is not improving, then you should consider. Patients who are having cyanotic episodes, and a lot of these is mainly you're doing to make sure you're not missing anything. That's why you take them to the OR to do a full thorough assessment. And especially if they have worsening symptoms. You have done the conservative treatment, but they are getting worse. Next, please. We talked about that. Yep. Next, please. Just showing you a video of supraglottoplasty, what it is. So we are doing a full airway assessment, and similar to that patient earlier we saw, has some arytenoid prolapse, has short AE fold. I commonly use cold steel, so you will see I'm palpating for laryngeal cleft. In this case, we have endotracheal tube in, but I'm just dividing the reepiglottic fold. So you divide one side, then you divide the other side. You just make a cut. What it does is it releases. So if you think about it, a box which is pulling everything down, you're making the cuts to release that so that the larynx opens up. And then you are trimming the arytenoid mucosa You're just trimming some of the mucosa. Um, and that basically will help open up the airway, cause it less floppy. Again, keep in mind it might not get rid of the stridor completely. They will still have a little bit of stridor post-op, but it should be much improved from where you started. And it'll continue to improve because as the healing happens, the cut will scar down, and that will basically slowly you'll see that the stridor is getting better. But key thing is sometimes in the immediate post-op period, they'll still have little noisy breathing, and people get worried like, oh, did the surgery not go well? That is common because you don't want to over treat it, because one of the key things we worry about in the supraglottoplasty is we don't want to end up making it supraglottic stenotic airway. So it's better to be a little conservative because most of these things will get better with time. Next, please. Next. Uh, so one of the concern is, do supraglottoplasty cause aspiration? The surgery itself does not cause aspiration. For many years, people used to think like there were reports in the past, but it has been debunked now. So that by itself doesn't. The key thing is having a pre-op assessment. So if you know ahead the kid is aspirating, the kid will more likely not aspirate after your supraglottoplasty because you've fixed the problem. You've made it better for the kid. So more likely they'll get better. The ones who do not get better usually have some kind of neurological stuff going on. So that's the key thing is if you've assessed before and seen that the kid is aspirating, it is actually good to go ahead and do the supraglottoplasty because more likely you will make it better, but you won't make it worse unless you have done something wrong. Like, um, next, please. Next. Sometimes you might have, uh, and again, for the ENT folks there, they need to do a full thorough assessment because sometimes you might have a laryngeal cleft, which is there along with the supraglottoplasty. So you can combine your treatments as well, but it is important to identify. So in conclusion, all patients with laryngomalacia should have some form of swallow assessment, whether it's a clinical assessment, combine it with the fees. That's at least the basic thing we should be done. And a small number of patients might.
Dr. Mudd, I think you've cut out.
It just keeps kicking me out every now and then.
So you just said
Just to add,
breast stomach.
yeah,
Next slide.
yeah, I think we're done, right? I can't see the
Yeah.
slides again.
So the last slide we had here is that as part of our conclusion, supraglottoplasty is indicated when
Yeah.
patients
See,
improve
so
their
in
swallow
appropriate
function.
patients, the supraglottoplasty does improve the swallowing. It doesn't cause aspiration. A lot of times you might have to, uh, in my mind, the speech pathologist is the key person in managing these patients, and the speech pathologist plays a huge role. Keep in mind, these are anxious patients. Their parents are anxious. They are worried about the breathing. They're worried that the kid is not growing, and you can make a big difference by just doing some alterations, giving them advice, taking them along, and also closely following up with them to make sure the kid is progressing in the right direction. Next, please.
That's it. It's just the record.
That's it. Okay. Any questions? I don't like it when people don't ask questions. It means either
Yeah,
this was
Deepak.
too boring. Yeah.
Yeah,
It,
Deepak. In case of post supraglottoplasty,
mhm,
when do you start oral?
right away.
Mhm.
But
Right away.
what we do is right away, in the sense whenever the kid is awake enough. So if I have done it earlier in the morning, then in the afternoon the speech pathologist goes by and sees the patient and talks to them and sees what is safe for them. If it is done later on in the day, then they get to see next day morning and then they go home. For me, the key thing is
Do-
the speech pathologist has to see the patient before they go home. It's reassurance to say where they are, and also you're making sure the kid is not having any issues, and it reassures the parents as well. The other thing, um, what was I going to say? Yeah. Um, the thing is, if you don't do that, and people worry that, oh, it is the kid is aspirating or aspirates post-op, um, you don't alter that part of it. But what happens is the kid just needs some help to just understand what is safe for that immediate post-op period, and then you follow up in a month. By then things would have improved dramatically. So even if the kid was aspirating, you're just sending them home on what is appropriate, thickened, or whatever diet they should be on. And when they come back in a month, the breathing is much better. Then you do another assessment to say where they are, and then they can be followed up if needed or discharged based on how they are doing.
do you start breastfeeding immediately on the same day in case if the child is already breastfed?
Yeah.
Yeah.
Okay.
Mm-hmm.
In
Yeah.
case
Yeah.
if the child is not being breastfed, from the birth till the surgery, like 2 weeks or 3 weeks for some
Mm-hmm.
various reasons,
Mm-hmm.
and preterm
Mm-hmm.
babies, or the child is not able to swallow, so maybe they'll
Mm-hmm.
be put on feed tubes or something like that. So in that case, so you will
Mm-hmm.
start NG feed NG tube feeding immediately after the surgery, and then how
Yes.
long you will wait for the normal feeding or breastfeeding to start.
So I can speak to this, Dr. if
So
you want.
yeah.
So,
Yeah. Yeah.
I mean, there isn't a specific time period for each kid. It's very kid dependent, very patient specific. And I think the quicker we can get them, you know, taking things by mouth, whether that be nursing or their bottle or whatever may be, the better. We're obviously not going to try if it's a patient who's never been fed by mouth because they've been exclusively tube fed for whatever reason. We're gradually starting, whether it's passy dips or little detached nipple. We want to encourage the positive oral experiences, and getting that as early on as possible so that we're, helping them be successful in that, and also reducing any potential, aversions or things like that. But always doing it safely and always doing it in conjunction with whatever nutrition they're getting, because we want to make sure that our kiddos are getting calorically what they need. And then also something that I think about is parents oftentimes expect a fix with their noisy breathing. So it's a matter of educating parents, saying like it's not going to change right after the surgery. It's hopefully going to get better, but same thing with the swallow. It's not going to be an immediate thing. It's something that we're going to be dynamically assessing each time you come in and tweaking and making modifications.
Yeah. The
Thank
key
you.
thing is, a lot of times what happens is someone has labeled the kid as something, and people give less importance to the feeding part of
Mhm.
it, and just say like, okay, the kid is NG tube fed, go home on NG feeds, we'll see you back in 2 months. You've lost an opportunity there because the kid has not developed the swallowing skills. So you missed out on that early swallow development, and then you are struggling a lot more. So that's why it is important to have that assessment. And obviously if the kid is not safe, that's a completely different picture.
Right.
But majority of the patients, what we see, they do well with their swallowing once you have come up with an appropriate plan. So that's the key message to learn is don't go by what someone has said and just let it go by. You need to do your own assessment to say what is this kid safe to feed and how much this kid can feed. And it's okay to take it gradually, but don't miss out completely to say, okay, the kid is being fed NG, let the NG tube be there. We'll tackle it when time comes. Sometimes you're not helping the baby then.
And oftentimes I find that, they surprise us, these babies. They haven't been fed at all or nursed at all. And then when they're able to breathe and when they're able to potentially coordinate this suck, swallow, breathe, they surprise you and they do more than you even considered or thought was possible for them. So always talking to families from the get-go, even with tube dependent NG or G tube fed babies, thinking about from the beginning what a dual feeding system, and I know Lauren talked about this, what that looks like. So yes, the primary nutrition is through the enteral feeding. However, we're also going to try oral feeding experiences and work towards progressing and increasing that volume they're getting by mouth as safely and effectively as we can.
So we have some questions from Ravish Zaidi. How do we counsel mothers who are determined to continue exclusive breastfeeding despite signs of feeding difficulty in the infant?
Oh, that's a good question. It can get very tricky, especially when mothers come in with this plan of, they're home and they're able to feed their babies. They want to continue. So I feel, and I think Dr. Mehta, you would agree, that we tend to be a little more liberal with breastfeeding. We find that mother-baby dyad and how babies nurse, they tend to do better in the fact that the flow rate and the way they're expressing the liquid it's kind of, they're met where what they can handle in a way. But oftentimes when the cases are more severe and babies are having a hard time breathing, or mother produces a lot of milk, has a strong letdown, and they can't keep up, it's a hard conversation. So we always support the mother and we say, these are the things that can be done. Maybe you can pump a little bit, hand express some milk beforehand to eliminate that heavy flow and reduce that overwhelm that's happening. And the signs that you're noting when, your kiddo pulls off the nipple because they're not comfortable or they're overwhelmed. So a lot of times it's pumping. If it's an electric pump they have, great. If it's a hand pump, if it's their hand expressing, we're encouraging that. Very rarely we'll say, don't nutritively breastfeed. It's a very rare thing. And then another consideration is position of mom. So even in clinic, it can be a little bit different for our mothers, but we will recline them back so that the baby's nursing on top of their breasts, more like facing forward. And just to decrease like that gravity helps decrease that the flow rate. So little modifications like that before having to, tell mothers that they can't. It's very rare that we say don't breastfeed.
Are there any recent studies comparing outcomes of exclusive breastfeeding versus mixed or formula feeding in infants with laryngomalacia?
Not that I'm aware of.
Yeah, I don't think there is a study as such, but our overall experience has been that you can be a little bit more liberal with breastfeeding compared to formula feeding, and a little bit easier to modify things. I worry less when the kid is exclusively breastfed, and some of the modifications what Natalie was saying, that helps a lot.
Mhm.
The third question is, what follow-up plan should be in place to ensure growth and nutrition are not compromised while continuing exclusive breastfeeding?
So yeah, this is a tough one because how do you know how much they're transferring, right? And so we do work a lot with our registered dietitians. We work with lactation consultants. You can do pre and post feeds. How accurate and reliable those are kind of iffy. But sometimes we even talk about with moms, they have baby latch, and then maybe you top them off with a little bit of fortified express breast milk or fortified formula. So we're allowing for the breastfeeding, and then we're supplementing with the formula or fortified express breast milk, or just more express breast milk. Weighing as often as we can to make sure that the weight is going up. And then from there, just making modifications. So if the baby isn't gaining weight, then maybe it's, we bottle feed for the first 10 minutes, and then we allow for mom to nurse for the last 5 to 10 minutes. So just being very careful and very considering what the weight actually looks like, and because we really don't know how much they're transferring.
Yeah. So last question is, are there any specific breastfeeding positions or techniques that can help reduce stridor or improve latch in these infants? Some of these you have touched, but Natalie, it might be good to just go over them again.
Sure.
So that specifically for breastfeeding, what other different things can be done?
First, I'd like to say I'm not a breastfeeding expert. So our lactation consultants, Lauren is one, and our lactation consultants are ones that, people we refer to help us with this. So things that I have noticed over my time working as a speech pathologist and in my experience are putting breastfeeding babies or bottle fed, doesn't matter, but in this case, breastfeeding more in that side position where their whole body is more on their side is great. Also with mama, more reclined back. The thing with being back, then if they're noisy breathers and having a hard time, that may be difficult. So having mom lay on her side to help optimize that's kind of more sideline position during feeding to help with the stridor.
Yeah, sometimes the side position, like Natalie, it would have been good if there was an infant in your lap.
I know. Here, like this.
Yeah, where's the face?
I know, right here.
And sometimes you can have the face away as well. No, for breastfeeding, is different. For bottle feeding, you can turn them away a little bit as well. If they are bottle feeding, that's another position. Sometimes it works, but it's mainly modifying those things. Did that answer your question, Zaid? Any other questions? Okay. If there are not any more questions, thank you all for your attention. Thank you, Natalie, as always.
Yep.
And thanks, Thiru, for putting this together.
Thank you.
In spite of being
Yeah.
in Greece, you still managed to join in. So
Yeah, thank you so much. Once again, it's a wonderful, talk and clarifying all the things. And so we are really fortunate enough that you guys are able to make it every Sunday of every month. And hopefully we will finish this in 2 or I think 3 more talks are there. So
yeah, there might be
we'll finish
more.
it.
We'll figure out. Unfortunately, I don't know if Dr. Raul managed to join in or not, but she's in Stuttgart for the ESPO conference. So
Okay.
so she might join. She'll join in next time. But we have
Yeah.
a lineup. But we might be able to add 1 or 2 more sessions after
Sure.
this current thing as well, based on your interest. The main thing I would like to get is some feedback from you guys to say it is worthwhile or not. Or sometimes we keep talking, thinking that it's okay,
Definitely.
but just give us some feedback to say this is all
Yeah,
good,
definitely. And I
this
mean,
is
I've
not
been
good.
speaking with them, and everybody is happy about it because we have started from the basics and we are slowly moving a little higher up.
Hmm.
So every single talk is useful for some people, those who have
Hmm.
just started and those who are in the middle stage, and
Hmm.
maybe we can bring all of them to the next stage. So
Yeah.
definitely it is useful. We'll keep doing it. And
Hmm.
thank you very much for putting it together. Thank you again.
Of course.
And thank you,
Thank you.
Natalie. Thank you.
Of course. Yeah, my pleasure.
Yeah, thank you. Bye-bye.
Bye,
Bye.
everyone.
Bye.